Which of the following is the most common risk factor associated with aortic dissection? Smoking. B. Atherosclerosis. C. Marfan's syndrome. D. Hypertension. E. Bicuspid aortic valve. Answer is D. Hypertension. Answer D. Although all the choices are risk factors for aortic dissection, the most common is hypertension. Though approximately half the number of patients with Marfan's syndrome develop aortic dissections, 10% of all dissections are in Marfan's patients. Question 2. Which of the following is the most common symptom seen in pulmonary embolism? A. Dyspnea. B. Chest pain. C. Unilateral lower extremity edema. D. Palpitations. E. Hemoptysis. Answer is A. Dyspnea. Summary. Answer A. Dyspnea is the most common symptom of PA, followed by pleuritic chest pain. Neither symptom is sensitive or specific for the diagnosis, and a substantial proportion of patients with PA only have vague complaints such as lightheadedness, dizziness, or palpitations. Additionally, PA is commonly found at autopsy in patients who were suspected to have died of other causes. As such, it remains an underdiagnosed condition due to variability in clinical presentation. Choices C, D, and E are all seen in PA, but each occurs 50% of the time. Question 3. Which of the following is true regarding pericardial effusion? As little as 50 ml of pericardial fluid can cause abnormalities on the cardiac shadow on chest X-ray. B. Beck's triad is seen in less than half the number of patients with signs of tamponade. C. MRI is the diagnostic test of choice. D. Blind pericardiocentesis is the treatment of choice for stable pericardial effusions. E. Electrical alternans is the most common EKG abnormality. Answer is B. Beck's triad is seen in less than half the number of patients with signs of tamponade. Summary. Answer B. Pericardial effusions are seen as cardiomegaly on chest X-ray when approximately 250 ml of fluid has accumulated around the heart. Beck's triad of hypertension, muffled heart sounds, and jugular venous distension occurs in 25% of patients with tamponade and should not be relied upon to make the diagnosis. Echocardiography, not MRI, is the diagnostic test of choice in most cases. CT scan may add helpful information but is not required. Blind pericardiocentesis should only be performed in unstable cases of tamponade when echocardiography is not available as the complication rate is high. Tachycardia is the most common abnormal finding seen on EKG, and decreased voltages may also be seen more commonly than electrical alternans. Question 4. Which of the following is most effective in reducing mortality from acute MI? Metoprolol. B. Aspirin. C. Nitroglycerin. D. Abciximab. E. Morphine. Answer is B. Aspirin. Summary. Answer B. Antiplatelet therapy with aspirin is still the most effective and cheapest medical therapy for treatment of acute MI. No other single pharmacologic agent can boast of as large a mortality reduction, including metoprolol and abciximab. Nitroglycerin and morphine do not reduce mortality in acute MI, but they are effective in managing symptoms of angina. Question 5. Which of the following is classically contraindicated in patients with presumed acute digoxin toxicity? Transvenous pacing. B. Electrical cardioversion. C. Calcium gluconate infusion. D. Transthoracic pacing. E. All of the above. Answer is E. All of the above. Summary. Answer E. There are several classic contraindications in the setting of digoxin toxicity. The most commonly cited is to avoid using calcium to treat hyperkalemia that frequently accompanies digoxin toxicity, since digoxin inhibits the Na+K+ ATPase. Interestingly, while hyperkalemia is a reliable marker of digoxin toxicity, hyperkalemia is not the cause of death in severely poisoned patients. Death is caused by fatal arrhythmias induced by digoxin's direct effects on cardiac automaticity and excessive vagal tone, and treatment of hyperkalemia has not been shown to decrease the risk of death. While there is almost no evidence to support the idea that stone heart teni of the myocardium will result from calcium administration in the setting of hyperkalemia-associated digoxin toxicity, elevated levels of intracellular calcium are already present, and hyperkalemia is not the chief problem, but rather reflects the degree of toxicity. Therefore, intravenous calcium should not be used to treat hyperkalemia in digoxin toxicity. In addition, patients with digoxin toxicity have an exceptionally excitable myocardium, so transvenous and transthoracic pacing as well as electrical cardioversion are all classically contraindicated. Atropine can be used as a temporizing measure in patients with severe bradycardia, but Fab fragments should be given as soon as possible after the diagnosis of a digoxin-associated arrhythmia is made. While there remains scant evidence, there is a theoretical increased risk of developing more malignant arrhythmias in response to pacing and cardioversion, example, ventricular fibrillation and pulseless ventricular tachycardia.